Before I begin, I want to express my sincere appreciation to Dr. Muhammad Abdul Sattar and the Bangladesh Head and Neck Society for the kind invitation to share some time with you this morning. The topic I have been assigned to discuss with you is that about the contemporary management of thyroid cancer and uh, what changes have taken place over the course of the past few decades into our modern thinking. As we know, thyroid cancer has uh, a steep rising incidence in various parts of the world. In fact, in the United States, it's called the fastest rising cancer. But this is a false understanding of the epidemiology of the cancer. And I will touch upon that. Uh, because the autopsy incidence of thyroid cancer in the United States is about 10%. And with a population of 360 million, there are 36 million Americans walking around on the streets of America with thyroid cancer, and they live their normal life. So I think we need to put some brakes before we put our hands in action. Let me share my screen.
Screen share.
Uh, okay. So the title of my topic is Dispelling Old Myths and Misconceptions in the Management of Thyroid Cancer. And the reason I chose the particular topic is there is such a deep amount of ingrained philosophy in the management of thyroid cancer all over the world that uh, it is hard to have people erase the established tradition because that's how their seniors, their professors, their institution, their colleagues, and in their community, thyroid cancer is being treated. So, for the next 30 minutes, I would like you to put all of your understanding of thyroid cancer behind, clean the slate, and let's learn what we know about thyroid cancer today and how we should treat the disease. The myths and misconceptions are not supported by any acceptable data. And that is why it generates controversy in the management of thyroid cancer. And the controversies are with relation to the extent of thyroidectomy, the role of elective node dissection, the extent of neck dissection, the role and benefit of radioactive iodine treatment, the role of molecular markers. We are in the molecular era, and the need for adjuvant therapies and the follow up strategies. All of these controversies are based because thyroid cancer is not one disease. It is a spectrum of a variety of different diseases with different biological behaviors arising from the same cell of origin. So, controversies can be resolved with the availability of solid data and new knowledge, which leads to evolution in the management of thyroid cancer. Now, there are numerous controversies and misconceptions. I have listed a whole list here. I will not have the time to go through each of these, but I will read out to them and will touch upon a few to resolve the issue. As I said at the beginning, there is a misconception that the incidence of thyroid cancer is rising. Is it truly rising, or we are identifying clinically occult, asymptomatic uh, cancers which do not need to be diagnosed and they do not need to be treated because it will not impact upon patient's life. Age 45, for example, was thought to be an appropriate age to stratify between low risk and high risk patients. That's not no longer true. The size of a primary tumor within the thyroid gland uh, dictated the extent of surgery and adjuvant treatment. That is also not true. Multifocality was considered a negative prognostic factor Not quite true. You are doing a diagnostic lobectomy, and the pathology report comes back 1 week later that it is carcinoma, and the knee-jerk reaction is completion total thyroidectomy. Is it really necessary? So that's a question we need to answer. If you have a palpable node in the neck, that doesn't mean patient needs total thyroidectomy and radioactive iodine treatment. Uh, what is important is to risk stratify your patients. And other misconception is if you have follicular carcinoma, everybody needs a total thyroidectomy because of the risk of distant metastasis. That is not quite true either. So I think all of these issues need to be addressed. And finally, as I mentioned, the misconception is that all patients need subtotal or near total thyroidectomy. All patients need postoperative radioactive iodine ablation. TSH should be brought down to nearly zero, and patients require annual whole body radioactive iodine scan as a follow-up for following the patient. And the fundamental question is, do we need to treat every papillary carcinoma? And the answer is no, you don't need to. And I will expand upon that also. So let's start with the beginning. The first myth is that the size of an intrathyroidal primary tumor impacts on outcome. Remember, I'm using the word intrathyroidal tumors. Whether it is 1 centimeter, 2 centimeters, 3 centimeters, or 4 centimeters, does it make a difference? And the answer is no, it does not. Here is our own data, 10-year survival for patients undergoing thyroidectomy for tumors ranging from 1 to 4 centimeters. As long as the tumors are intrathyroid and differentiated carcinomas, the disease-specific survival at 10 years is 100%. You cannot make it better. It is larger tumors bigger than 4 centimeters, or most importantly, tumors with gross extrathyroid extension, where you see declining prognosis as the years go by. But for the intrathyroidal tumors, the green line, the survivorship is essentially the same regardless of the size of the tumor. And it is not only our own data. This is data from the National Cancer Database in the United States, a study of over 62,000 patients followed for 10 years. The survival rate at 10 years for tumors up to 2 centimeters and 2 to 4 centimeters is more or less the same. So you cannot have a larger data set than this. Another myth is multifocal papillary carcinomas have worse outcome compared to unifocal lesions. So we looked at our own data at Memorial Hospital and noted that if papillary carcinoma or a differentiated carcinoma, whether it is unifocal, UFD, or multifocal, the 10-year survivorship is the same. It doesn't make any difference as long as the tumor is within the capsule of the thyroid gland. Whether you have one focus, two foci, or five foci, it makes no difference whatsoever. And here are the 5 parameters of outcome for unifocal disease and multifocal disease. At 10 years, these are all patients undergoing lobectomy. Mind you, these are multifocal tumors confined to one lobe of the thyroid gland, and they are a lobectomy. Recurrence in the opposite lobe in unifocal disease or the multifocal disease is the same. Risk of nodal recurrence, same. Distant recurrence-free survival, 100% for unifocal or multifocal disease. Disease-specific survival, 100% in both groups. So multifocality is not a negative prognostic factor. Another myth that every patient with thyroid cancer requires total thyroidectomy. So we did a careful study about this of 884 consecutive patients, their match pair analysis, their all the parameters you see here, patient's age, gender, T stage, histology, risk group, and were compared in the match pair analysis, and 362 underwent lobectomy and 522 had total thyroidectomy for equivalent clinical parameters. The five measures of outcome: local recurrence-free survival, neck recurrence, distant recurrence, disease-specific, and overall survival are exactly the same between lobectomy and total thyroidectomy. There is no difference in the five parameters. Based on this data and data provided by other institutions, the American Thyroid Association made a major revision in their guidelines in 2015, and now they recommend lobectomy for intrathyroidal tumors up to 4 centimeters. Remember, in 2009, the recommendation was total thyroidectomy for anyone above 1.5 centimeter tumor. And this is a radical change in their stance because of the solid data provided by Memorial and other institutions. And now the current recommendation is lobectomy for tumors up to 4 centimeters, which are intrathyroidal and unilateral. And it's again, as I said, not our own data. This is the national data of nearly 62,000 patients undergoing lobectomy versus total thyroidectomy. The 10-year survivorship is exactly the same for tumors up to 4 centimeters. So, radical change in the understanding of the disease and its management. One size fits all is no longer the norm of care. Tailor your treatment to the patient and the patient's tumor. Another myth is you do a thyroidectomy and the pathology report comes back that there is microscopic extrathyroid extension. The knee-jerk reaction is patient gets radioactive iodine. Do we have evidence that it is necessary or does it benefit the patient? So here are our own data. Patients with no extrathyroid extension and patients with microscopic extrathyroid extension have exactly the same 10-year survivorship, two green lines. It is the gross extrathyroid extension which declines survival with passage of time. But microscopic presence of tumor on the capsule has no prognostic or therapeutic implication. Based on this, the American Joint Committee on Staging revised thyroid cancer staging, and the microscopic extrathyroid extension is now no longer considered a factor in upstaging the tumor. It has been removed. It is only gross extrathyroid extension, whether it is anterior to the strap muscles or posterior to the vital structures, which upstages the tumor. Another myth is that if you have a nodal metastasis, patients need total thyroidectomy. Not necessarily true. Here is our own data recently presented at the American Thyroid Association meeting comparing patients undergoing lobectomy versus total thyroidectomy for N1B disease, those with palpable lateral neck metastasis. There are selection criteria. If the disease is unifocal and intrathyroidal, and the nodal metastases are on the same side of the neck, lobectomy and neck dissection gives you the same outcome as total thyroidectomy and neck dissection followed by radioactive iodine treatment. And here are the two parallel lines at 10 years, total thyroidectomy versus lobectomy. And not only survivorship, the recurrence-free survival is also exactly the same, two superimposed lines. So be selective. Nodal metastasis is not an indication for total thyroidectomy on every patient. If the nodal metastases are unilateral by clinical exam and by imaging, and the primary tumor is on the same side of the nodal metastasis and is intrathyroidal, and the opposite lobe is normal, lobectomy and neck dissection will provide you comparable outcomes. So, what matters in thyroid cancer? Is it what we do, or is it the patient and the tumor? So, the prognostic factors of uh, independent impact on outcome have been well recognized for nearly 40 years now. The first article came from Mayo Clinic in 1986 with the eponym AGES for age, grade, extrathyroid extension, and tumor size. Since that time, several other prognostic scores have been published from the Leahy Clinic, from the Mayo Clinic, again from Karolinska, and from Memorial Sloan Kettering, my institution. The prognostic factors are the same on independent data sets from various institutions. Look at that patient's age, and age. That is the single most important prognostic factor. Extrathyroid extension, tumor size, and presence of distant metastasis are independent factors impacting on outcome. Based on these prognostic factors, we can devise risk groups. Low risk group are patients younger than 55, generally females, with small tumors which are intraglandular and there is no distant metastasis. They fall into the low risk category. The opposite is older patients, generally men with larger tumors, extrathyroid extension, or distant metastasis. They fall into the high risk category. And then you have older patients with good tumors and younger patients with bad tumors. They fall into the intermediate risk group category. Let us see what happens if you use the risk group stratification. In the low risk group, and again, these are nearly 2,000 patients, the 10-year survivorship in the low risk group is 100%. You cannot make it better. And remember, this is independent of the treatment given, the extent of surgery, radioactive or iodine or no. This is based only on the patient factors and tumor factors. In the high risk group, clearly there is declining outcomes with passage of time. And in the intermediate risk group, the survivorship still is almost as good as low risk group, up to 99%. So now the common myth that all patients after thyroidectomy need radioiodine ablation and treatment needs to be revised. Here are the current recommendations for the use of radioactive iodine by the American Thyroid Association. For T1 tumors, no, there is no recommendation for radioiodine. For T2 tumors, no. For T3 tumors, no. For microscopic extrathyroid extension, no. For N1A disease, low volume central compartment lymph nodes, does not warrant the need for radioactive iodine treatment. Even in